founder of the Sudden, I'm the founder of the Sudden Cardiac Arrest Foundation and now working as a consultant and managing the Cardiac Arrest Survivor Alliance program. And so I'd like to give you a little bit of background about who we are, what we do, and then a little bit of background information, what you should expect. And then I'll introduce our speaker. The Sudden Cardiac Arrest Foundation was founded about 20 years ago, and our vision is to eliminate preventable death and disability from sudden cardiac arrest and support people affected by SCA. Our mission is to raise public awareness of sudden cardiac arrest and promote initiatives that save lives through education, research, and community. So we're celebrating our 20th anniversary this year. The Cardiac Arrest Survivor Alliance is a program of the Sudden Cardiac Arrest Foundation and a place for anyone who's touched by cardiac arrest to participate. We foster an online community for patients, families, friends, caregivers, lay responders, and advocates. And we provide peer support, information resources, and access to experts to help community members recover, re-engage, and thrive. CASA is a home for hope and healing. Before I introduce Dr. Kim, I'd like to give you a little housekeeping information. First of all, this webinar is presented for informational purposes, not for medical advice. If you need medical advice, you should contact your physician. The presentation will last for about 20 to 30 minutes and will be followed by a Q&A session. You have the option to turn on your camera unless you prefer to remain anonymous, and you're welcome to post questions and comments in the chat box. If you do post a question or comment in the chat box, however, you will no longer be anonymous. This webinar is being recorded and will be available soon in the video vault in CASA and also on our YouTube channel. Now I'd like to introduce Dr. Jonathan Kim. Dr. Kim, we're very, very honored that you were able to join us today and present information on your most recent study. Dr. Kim is an associate professor of medicine and founding director of sports cardiology in the Division of Cardiology at Emory University School of Medicine. In addition, he holds an adjunct professorship in the School of Applied Physiology at the Georgia Institute of Technology. He received his Bachelor of Science at Emory and was a Fulbright Scholar before attending Vanderbilt Medical School. Dr. Kim completed his residency in internal medicine and pediatrics at Massachusetts General Hospital and completed his cardiology fellowship at Emory. He was a chief fellow there in 2013 and 2014. In addition to his clinical role, Dr. Kim conducts NIH funding, sports cardiology research at Emory. He is the team cardiologist for the Atlanta Falcons, Braves, Hawks, United, and Dream, and he is the team cardiologist for sports medicine at Emory and Georgia Tech. Dr. Kim is a member of the NBA Cardiac Advisory Committee and NFL Cardiovascular Task Force. He is the co-medical director for the AJC Peachtree Road Race in Atlanta, Georgia, and he is the current chair of the American College of Cardiology Sports and Exercise Cardiology Council. So, Dr. Kim, we are so honored that you were able to share your insights on your latest research with us today. So thank you.
Thank you, Mary, for the very kind introduction, and thank you for the invitation to present. For some of your members, had a chance to get to know both you and some other members over the last few months, in part actually as it related to hearing about this study and then some other potential ways to collaborate. And I may mention a little bit about this specific study and how I think collaboration and work with the foundation can continue to provide really good data. And I think everybody listening here will see exactly how important these data are over the last really 20, almost 25 years, really, because this is the second of these studies. And I suspect survivors may know other individuals um, who have had events during half marathons and marathons. So I'm going to talk about this study. We call it the RACER study, the Race-Associated Cardiac Event Registry. The point of the registry has been to analyze and study sudden cardiac arrest events that occur during long distance running races in the United States. We define these as half marathons and marathons, and I'll get into a little bit more detail about what the inclusion criteria was. So you kind of heard already about my disclosure, so I'll move forward to really understand exactly these data and kind of how to contextually think about where this fits in. We have to talk about Racer 1. So this study was really entitled Racer 2 as we were looking at events that occurred between 2010 and 2023. But there was a first study which looked at the incidence of cardiac arrest during half marathons and marathons between 2000 to 2009. So overall, you can kind of think about this as a continuum, as mentioned, over almost 23 years of events. So I want to acknowledge my kind of partner in crime in this. Many of you may know of his name, Dr. Aaron Bagish. He, as well as a sports cardiologist, was formerly at Mass General as well in Boston. That's how he and I got to know each other. He's currently in Switzerland. Um, and we have teamed up as kind of co-PIs for this entire study. So the first RACER study was actually published in 2012. And to summarize exactly what we found, let me just first off, that sudden cardiac arrest during half marathons and marathons in the US was pretty rare overall. So the incidence was about 1 in 200,000 race participants. But when you look at demographics, specifically men, and then events that occurred during marathons versus half marathons, what we found was that really men who engaged in the marathon distance specifically were the highest risk demographic. And that risk actually increased over the decade. So from 2000 to 2004, then from 2005 to 2009, the incidence actually increased. The most common cause that we identified was actually a genetic heart disease called hypertrophic cardiomyopathy. This is a genetic heart condition in which the heart pathologically hypertrophies. So it's thicker and it weighs more than it should and is not driven by any other cause except for an underlying genetic predisposition. And one of the risks of having this condition is potentially sudden cardiac arrest. One of the key findings, in addition, was that the case fatality rate was 71%. Another way to look at that, case survival rate of about 29%, improved compared to the survival rate of out-of-hospital sudden cardiac arrest in general. You'll hear this number later in the talk, but that's about 10%. And survival here was predicted by the initiation of bystander CPR. So a runner goes down, somebody, either another runner or somebody else begins CPR. That was the primary predictor of survival. But again, that 30% clearly work to do. And after Racer 1, within the race medicine community, this is where there began a huge push about CPR education, the strategic location to house EMS services during these type events, and really a focus on the emergency action plan as we talk about specifically for these events. So that leads to the question, of course, so why update this? Why look at this again? We published these data. What were some of the rationale? And there was actually a few reasons. First off, if you look at participation in these events, almost 3 times the number of runners completed marathons, half marathons between 2010 to 2023 compared to the prior period. Now, acknowledging that there were an additional 3 years, this wasn't just a 10-year comparison to 10 years, but nonetheless, substantial number of participants increasing in popularity. I just mentioned that one of the points of emphasis after Racer 1 was that there was room to improve. So, of course, the question, perhaps the primary question that we really wanted to look at, have changes in these EAP protocols and a focus on how to improve survival, knowing where the gaps were made a difference. We wanted to look at changes in epidemiology, changes in both the incidence but also causes. If you look at common causes of sudden cardiac arrest and death in, say, young competitive athletes, what we've learned is that there's been a shift. I mentioned that the most common cause was hypertrophic cardiomyopathy. It used to be believed that was the most common cause overall when you look at athletic individuals who die during sport or who suffer sudden cardiac arrest. The issue, though, is over the last decade or so, that's shifted. Among young athletes, HCM, as we call it, is not the most common cause anymore. The most common cause is actually an unexplained event. So, an autopsy that's completely normal. So, we wanted to look and see if there's been a shift in epidemiology as well here. Of course, another decade plus, let's see if there have been changes in terms of race participant demographics. And yeah, oh, by the way, we just went through a once in 100 years pandemic. So, not necessarily has the virus, SARS-CoV-2, led to more problems, but really more so the pandemic. As we look at COVID-19 as a whole, clearly there were pressures in the healthcare system, other issues, downstream consequences that we now recognize that impacted healthcare across the board. So we wanted to see, did the pandemic potentially have an impact in terms of outcomes here during long distance running races? So the aims of the study were threefold: to determine the contemporary incidence of sudden cardiac arrest and death during these events, as again between 2010 to 2023, but also looking at specific demographics, specifically by sex and race distance, to determine the etiologies associated with sudden cardiac arrest and death during these events, and clearly in comparison to RACER 1, and finally, to identify factors associated with survival. So in RACER 1, it was bystander CPR. Are there new factors that have led to improved survival? So this is a busy slide. Let me take a little bit of time to go through the methodology to make sure everybody understands what we did. And this was very similar to what we did in RACER 1. So in order to really have a apples to apples comparison, of course, you really want to do things pretty similarly to the first time. Otherwise, you don't know if your numbers are comparable to a prior study. So the first thing that we had to do was to have an appropriate denominator. If you're going to identify incidents, how many people are included within the overall study? And this is where we continue to partner up with a company called Running USA. Running USA is a large organization focused on running events in the US. And they, in collaboration with Athlinks, everybody knows Athlinks, which is a company that allows people to track running times, we're able to precisely identify the total number of race finishers over this 13-year time frame. Also, finishers by sex and race distance. We also had to make sure that we knew all of the races that existed in the US. And marathon events have really increased in popularity. So it's, as probably all of you know, they're not just in the big cities, they're smaller events around the country. We had to make sure that we identified all of these. And specifically, we wanted to identify those events that were certified by USA Track and Field. So we were lucky. Not only did we have collaboration with Running USA and Athletes, but we collaborated with USATF to identify the appropriate number of half marathons and marathons during this time frame. There were 443 events. Number two, we had to identify cases, of course. We leveraged similar strategies that we used in Racer 1, which was primarily the use of public search engines. These are high profile events, so very detailed internet searches can really identify most of these events. But as mentioned, there are a lot more people running these events, a higher number of races. So we utilized additional methodologies that were not available, period, prior to 2010 when we first did this. Number one, we actually had the contact information for every single race director for these events, and there are 317. Some race directors oversee multiple events, and this information is actually available online. So we reached out to these individuals. We actually were able to achieve contact with about 70% to see if we could identify additional cases. And as mentioned, we collaborated with USATF and we were able to review cardiac arrest claims submitted to USATF. So these are insurance injury claims that are submitted to the insurance carrier for USATF. Not every injury is submitted, but many are, and some of these included cardiac arrest. And therefore, we're able to try to identify more cases. So numerous methodologies to potentially identify cases. Then it was, once we identify cases, how are we going to identify cause? So again, leveraging public search engines, a lot of this disclosed in media reports. We were very careful. Obviously, these were very specific etiologies reported. If, for example, a media report stated somebody had a quote unquote heart attack, which is, of course, a very layperson term and can mean, frankly, almost any diagnosis, we actually didn't include that. It had to be a specific condition that we knew would be a cause of this that we included. Additionally, we identified names. And we then were able to identify contact information for many of these individuals. We reached out to them. So these were survivors or next of kin for, unfortunately, decedents potentially by mail, letters, email, social media to see if there would be interest in terms of collaborating in this study. If there was, we interviewed them and then we're able to obtain medical records or potentially an autopsy report. And then with these interviews, as well as medical information, that allowed precise information of demographics, of course, running exercise history, medical history, and then most importantly, the race, sudden cardiac arrest description, and what happened after the cardiac arrest. What was the emergency care like? So let's go through the results. And the best way to see the results of RACER 2 is to see in direct comparison to RACER 1. So, as mentioned, three times the number of race finishers, so a much higher volume. A total of 176 sudden cardiac arrest events were identified. You can see in comparison to Racer 1. And so, if you look at the incidence, this is zero point 0.6 per 100,000 race finishers. And that's almost identical, actually, to what was occurred in Racer 1. So, from a statistical standpoint, even though the number's higher, this is really unchanged. But what was dramatically decreased, and probably the most critical finding of this entire study, was if you suffered a cardiac arrest, what was the chance of dying? And what we found was a dramatic 50% reduction in terms of risk of dying by running a half marathon or marathon, as you can see by the numbers here. So there's a better way to look at these data, a little bit easier way, kind of graphically. So what I'm showing you here again are changes in the incidence of sudden cardiac arrest in blue, as well as the incidence of sudden cardiac death in red across different time periods. In gray here is Racer 1. In white on the far right is the total time period for Racer 2. And then you can see in the middle, the lighter gray, kind of splitting 2010 to 23 by 5 year or so time intervals. And what you can see is, again, in terms of the instance of SCA relative stability, you'll certainly acknowledge when you look at 2020 to present, there's been a little uptick. But if you look at sudden death, what you see is this dramatic decline regardless. So a 50% reduction. And so another way to look at the data is looking at both case fatality and case survival rate. And really, I just want you to focus on the far left, Racer 1, and the far right, Racer 2. And really, what you see is a complete flip-flop. So case fatality rate, which is in red, from 71% dropping to 34%. So case survival rate, as mentioned in the very beginning, 30% for Racer 1, double, 66% survival rate. And I'll provide some contextualization about what that means as we get near to the end of the talk. All right, so let's talk about some other specific subgroups. So we looked at key demographics. There are some challenges here. We used some statistical imputation methods because we weren't able to fully identify some cases as by sex as well as by race distance. But overall, through our statistics, we were able to affirm that men are at higher risk compared to women. It's exactly what was shown in Racer 1. And the marathon distance is a higher risk distance compared to the half marathon distance. But let's focus in on that key demographic, men who run marathons. As I mentioned, that's the highest risk demographic. And that incidence actually increased across the latter half of 2000 to 2009. But what you find now, comparing the overall time periods, again, relative stability overall. Again, the numbers suggest that it's a little bit higher, but from a statistical standpoint, it's actually pretty stable. But as mentioned, when you look at the latter half of the 2000 to 2009 decade, you can see an increase. And in the Racer 2 timeframe, what we found was that the overall increased incidence of sudden cardiac arrest from that 2020 to 2023 timeframe was really driven by men who run marathons. So that uptick that you saw, again, it's really driven by this specific demographic. Let's look at causes. This is a busy figure in this pie chart here, but I'll talk you through some of the key findings. So, as mentioned, there are a total of 176 SCA cases. The survivors are in red, the decedents are in blue in the pie chart. 48 of these individuals were unidentified. So we were potentially able to identify names and cause in about 128 cases. And within that, these are the individuals who are within this pie chart here. What we found was that, or I'm sorry, actually, of those 128 cases, 67 were able to confirm etiology. So there's 67 individuals here in this pie chart. And what we found actually was that the number one cause of sudden cardiac arrest is now coronary artery disease. So this is an individual who suffers kind of that layperson heart attack, an acute plaque rupture. They go down and they have to emergently go to a cath lab to open up a coronary artery. This is a very common cause of sudden cardiac arrest in the general population. Certainly, as we get older, coronary artery disease is a very common diagnosis. And what's interesting is that the former number one diagnosis, HCM, as you can see, is not even close to the most common cause anymore. It's whether you survive or unfortunately die from running a marathon. And similar to what we see among young athletes, actually the number two cause is actually either where you cannot find a cause. So these are survivors, and after an exhaustive diagnostic workup, you just can't find ultimately what happened. Or if they unfortunately died, the autopsy is negative, but the heart is completely normal at autopsy. And so you really don't know. And we call that autopsy negative sudden unexplained death. And then the other causes, as you can see, and certainly if you read the study, you'll be able to see kind of a potpourri of other conditions that we sometimes see as causes for young athletes as well. Perhaps maybe one of the things that's unique to a running event is hyperthermia or heat stroke. That as well was represented within this pie chart. All right, so this is a table showing those individuals for whom we were able to get complete clinical profiles. So 36 individuals consented into the study, gave us full interviews, and you can see these were 19 survivors and 17 next of kin. So there's a lot of information here, but really what I want to focus in on is this right here. So where do these events occur? The location of sudden cardiac arrest. And what you see kind of in the highlighted blue is that most of these events occur at the end of the race. And this is exactly what we showed in Racer 1. And it kind of makes sense intuitively, right? At the end of the race, runners are pushing the hardest. Of course, they've already been running for several hours or a couple hours if it's a half marathon. But once you push harder, that increases the risk. And so it's not uncommon that this is where you would believe most of these events occurred. But there's some other key findings to take away from these 36 individuals, some additional insights, as we say. So for those cases, so CAD stands for coronary artery disease. This again is the most common cause. What we found, and this is a little shop talk here, but not only was it the classic cause of a heart attack that we see with patients who present in the hospital, that's an acute plaque rupture, but we also saw evidence of demand ischemia, as we call it. So these are individuals who have a blockage that's very stable. It may be 70, 80, 90%, but it's not causing any issues. It doesn't cause a heart attack, but it's obstructing some blood flow. And so then you run a hardcore running event. You can imagine that adds a little bit extra stress and demand on the heart. And sometimes that can unfortunately lead to cardiac arrest. And we saw this in Racer 1 as well. So the point here is that we see both cases of kind of the classic heart attack, but also evidence that it is because an individual may be pushing hard and they do have underlying coronary artery disease that maybe even stable coronary disease that can be problematic. For those cases of autopsy negative sudden unexplained death, it's very important in cardiology that we focus on setting postmortem genetic testing. And that was performed in four of these seven cases. VUS stands for variant of uncertain significance. And all this is telling us is that sometimes in these cases, you can identify truly pathogenic mutations for specific heart conditions, but sometimes the uncertain mutations as well. And it just emphasized that this is a really important part of the evaluation of patients who really suffer. Even if you survive, genetic testing is really important prognostically for the patient as well as the patient's family. So this is really interesting. So in four of the cases of individuals who died, what we found in the postmortem toxicology was the presence of stimulants. So you can't equate this to causality, meaning like we can't say that it was overused caffeine that led to a sudden cardiac arrest. But certainly in my space of sports medicine, sports cardiology, I'm very weary of the use of stimulants in athletes, both young athletes and older athletes. And it just emphasizes this is kind of a burgeoning area of interest about the overall potential implications of stimulant use. As you can see here, these are mostly legal stimulants, caffeine, Sudafed, et cetera. But from a counseling standpoint, I counsel against stimulant use all the time. Does that mean that people need to give up coffee? Of course not. But sometimes the overuse of stimulants, monsters, Red Bulls, there's really high levels of caffeine. And I certainly, and I'll be fully submit this is kind of my own opinion here versus kind of evidence-based, but I always steer people away from this. So I found this to be a very interesting finding, and not only emphasizing the need that we need to study this more, but even how we counsel patients at presence. I think there's something to this observation that's really important. And so here's the other key finding of the study. So we talked about a 50% reduction in death. So for these, and again, this is a snippet, it's not everybody, but that you can certainly extrapolate what we found in these 36 individuals. All of these individuals received bystander CPR. So I mentioned that in RACER 1, that was a critical predictor of survival. But in RACER 1, only about 60% of the individuals that we were able to get full information on actually got bystander CPR. So this is important. It tells us that we are doing better. But what was really predictive of survival was actually immediate access to defibrillation. So these are some fancy statistic numbers, but the best way to interpret what I wrote here is that what was predictive of survival was to have a rhythm. So once you put an AED on that person, have a shockable rhythm. So the AED gets put on, it says you need to shock this, and you shock that individual. That is predictive of survival. And going back to bullet point 4 here, in those subjects who had no AED access, so it wasn't 100% AED access, and fortunately, all those individuals died. So, how do we put this all together? And this is really the key take home message of RACER 2. So when we think about out of hospital sudden cardiac arrest, there's really good studies about the efficacy of AED use. And I think for everybody listening to this, I don't have to preach that. Everybody knows that, particularly for survivors. So there are studies that have looked at casinos, airports, high schools where AEDs are present. And what we know is that if you have an AED accessible, the survival rate, which is a dismal 10%, that's the number that we start with across the board in the US, can increase upwards of 70%. So in some regard, that's kind of the top shelf number in terms of how good can we be? Because cardiac arrest is very serious. So we you can't really expect that you're going to have, unfortunately, as we would love to have 100% survival, but sometimes we just don't. 70% when you have AEDs around the corner, that's how you're going to have people survive. And this is kind of that top shelf number. We want to do better, of course, but we also have to kind of start where we know the data shows where the best numbers are. So we can actually include running events to this now. So survival rate now 66%. It's almost identical to that 70% number. And of course, these pictures just kind of emphasize that we're talking about events that run over 13.1 and 26.2 miles. So these are really complex geographic footprints. But it tells us that with these improvements in these EAP plans, with strategic placement, where you put these AEDs, where you have your mobile EMS services, it's really saving lives. We did have limitations in the study. You always have to acknowledge where the challenges were. No study is perfect. So our case ascertainment was not completely identical to RACER 1. As mentioned, we did have these additional methodologies to account for the significant growth in the industry. But what we did is we did a sensitivity analysis. And what that means is that we also just looked at the cases where there was a media report available. So we kind of just used the RACER 1 methodology for RACER 2. It turns out actually that 165 of our 176 cases, there was a media report that was available. And because of that, 165 out of 176, you can probably believe that the incidence of SAA was pretty much unchanged. So it's a way to address that limitation. And maybe even more importantly, of the 59 individuals who died, every single one of them had a media report. These are high profile events. When somebody dies during a marathon, they still garner a lot of attention. So we feel pretty confident that the apples to apples comparison from RACER 1 to RACER 2 was certainly there. Race finishers were used as a surrogate for race participants. So what does that mean? So what athletes documents is an individual who finishes. It's not a capture of individual people. So clearly what that means is that individuals could have been counted more than once. Marathon participants tend to like running marathons more than one. And so there's no doubt that there was some double counting that went on. But that was the exact same limitation that occurred in Racer 1. So it's an apple to apples limitations comparison because running USA as well in the original study, it was just race finishers, but it's an important to acknowledge. And in terms of reporting etiology, I mentioned we're only able to report little over half of the etiologies reported. That is the exact same catchment as we had in Racer 1. It's not easy when you're going back and trying to interview people. It's impossible to be able to get everybody to respond to questionnaires or to, for whatever personal reason, they may not want to be a part of the study. We acknowledge that up front. Certainly, if you have a loved one who died, it may be just emotionally too hard to do something like this. So, not able to get 100% of etiologies reported. And that always introduces then some element of selection bias in terms of who the people were who were consenting in. But when we did compare demographics between those who were able to attain etiologies to those who were unidentified, at least we can say that the demographics are almost identical by age and by sex. So, what's our primary conclusion? When you look at total incidence of sudden cardiac arrest between 2009 to 2010 to 2023, it's remained relatively stable, though we do acknowledge this unexplained increase since 2020. I'm sure some people are wondering, what do I think that is? To me, I think it is definitely not a SARS-CoV-2 problem. We know based on data from young athletes that there's not a lot of COVID-19 myocarditis that exists. I think this is probably more driven by what we saw in the general population, which is during the pandemic, a lot of people were kind of ignoring their own health care. People were scared to go to the doctor. People were not focusing on primary preventive care. And that was seen in the general population. I think that may have a lot to do with what we saw here. Coupled with that, I also wonder, even though the demographics haven't changed, perhaps a lot of the population has changed. So when we think about the pandemic, what's kind of the classic stereotypical story? People are cooped up all of a sudden, you can kind of get out and about as we head into 2021. People are quitting jobs. Like, you know what? I'm done. I'm going to go travel the world. A lot of people may shift to marathon running. I'm going to run a marathon. Like, it's kind of a life-changing event, really makes you appreciate life. And it just kind of makes you wonder then how many of these people may be new to the running field, also potentially contributing as well if they didn't know or focus on some of their basic healthcare. Those are theories, though. We weren't able to really address that in this study. But at least my thoughts about maybe what explains that. A final thought could be that anytime you look at epidemiology of sudden cardiac arrest and death, there's these weird blips, unexplained. Sometimes cardiac arrests come in a little bit of surges. We see that in young competitive athletes. Might have even explained why we said an uptick in men from 2005 to 2009, because it did kind of come back down from 2010 to 2019. So could it be that 2020 to 2023 is just a blip? And that if we do this study again in another 5 years, we'll see things kind of trend back down. It's really hard to say. All explanations are certainly possible. The other key conclusion, the risk of death, and I think this is the primary conclusion, has declined by almost 50%. And we think this is because of the enhancement and the focus on the emergency action plan, really specifically focused not just on immediate CPR, but on that immediate AED access and implementation of appropriate EMS services with strategic placement and deployment of AEDs and early defibrillation. And this is the final take-home point, and it really relates to the most common cause, as everyone saw. Coronary artery disease, ASCVD stands for atherosclerotic cardiovascular disease. Another way of saying coronary artery disease. That is the most common cause. And what's interesting, if you look from 2020 to, I'm sorry, 2000 all the way to 2023, that number has not changed at all. So if you look at men who run marathons, the highest risk demographic, overall, it's about 1 in 50,000 men who run a marathon will suffer a sudden cardiac arrest. So another way to think about that is every year, if you combine the men who run Chicago and New York, or New York and Boston, that's one man who's going to suffer cardiac arrest during that race. And it always bothers me when people say, it's rare. That's really one too many, in my opinion. So I really think there is an opportunity to focus on our primary prevention strategies for the masters endurance athlete. So for the individual, certainly these higher risk demographics. Does that mean that if you're a man and you run a marathon, you have to get stress testing and all this type of stuff before you train? Absolutely not. But what it means is that you need to focus on discussions with your doctor about your blood pressure, your cholesterol, smoking habits, all of these things. And if there are higher risk factors, perhaps that is a chance to see a sports cardiologist or a preventive cardiologist who has experience seeing athletes in discussing some potential individualized care plans about is it safe for me to run a marathon? A lot of these individuals were people who and we saw this in Racer One, were people who weren't taking their medicines. They're like, I'm good, weren't taking my blood pressure medicines. Um, Decided I wasn't going to take a statin, long history of smoking, things such as that, and events happen. There's obviously a lot of individuals who may still fit that bill and nothing happens to them. So this is not meant to be a fear warning as well. But I just think that that's the message. And as we've really improved the emergency care for individuals who suffer SCA during these events, I think the upstream prevention. So let's now start dropping the number of sudden cardiac arrest events in general is a primary focus, certainly in the sports cardiology world. So with that, I want to acknowledge the team. So this is our Racer 2 work group. I showed you a picture of Aaron. The other authors are listed here as well as pictured, but I'm picturing these individuals specifically. This is my team at Emory, who really were kind of the workhorses behind interviewing participants, identifying races, repetitive reach outs to running to runners who had events. It was a lot of work, and they deserve a lot of credit as well. And certainly their picture shown anytime I talk about this. And then, of course, acknowledging some of the organizations that we worked with. And here's the QR code. This is the study was published online, and it's available now. So you can probably Google it. But if you want to kind of take a picture of that QR code, I think the print version is going to be out pretty soon. Actually, I don't know the exact date, but it's obviously the online publication is there. And I'll stop there. Thank you.
That was really excellent, Dr. Kim. Thank you so much. We have a question in the chat. Did all of the events occur during the marathon, or were any of them reported closely after the marathon?
Yeah, no, that's a really good question. So we defined it as either during or within 1 hour after. And that's kind of a standard definition when people look at events that occur during sport. There's always the possibility. That's another limitation, really, is that somebody could have had something the next day, and we might have missed that one. And that happens. I've certainly had patients in my sports cardiology clinic who finish a marathon, were actually fine, and then 12 hours later they developed chest pain, and that would not have been captured. We did have one individual in this registry who unfortunately died of heat stroke, and they did not have a cardiac arrest, but they collapsed on course and then went to the hospital and unfortunately went into multi-organ failure and died within a few days. We felt it was appropriate, even though it wasn't a cardiac arrest, just by nature that it was clearly an event that occurred, hyperthermia being a big problem during these events that should be included. That is one other caveat.
Okay. Um, Somebody else asked if the data was separated by age. Are athletes under 35 years of age experiencing cardiac coronary artery disease or myocardial injury?
Yeah. It was. We certainly were able to identify all the cases. We did have age. It is always interesting when we see this, which is that the older individuals, because it's coronary disease, did better. You know, the survival rate for our patients who had a heart attack was more than 90%, which is pretty incredible, actually. And so they got a shock, they went to the cath lab, they got a stent, they lived. Um, when with the younger individuals, coronary disease is just not as common, and so they're going to be falling in within the other spectrum of other conditions.
Okay. And Zach has a question.
Hi, Dr. Kim. That was an excellent talk. I'm always really interested in, so I'm a survivor, and I've sort of gone through all of this workup, like I think a lot of people have when we have unexplained cardiac arrest.
Yeah.
And I'm struck by the frequency of these unknown events, right? And um, I'm curious if you could talk about like what is the state of work to try and figure out what these might be, right? Like genetics, we know only tell part of the story when we think about disease etiology. And I was really fascinated by the point about stimulants being some factor, right? Like how do we capture what the environment of that moment means for cardiac arrest outcome, right? And like when we deal with all these questions of like rare events and the challenges of like each individual when we think about predicting causality?
Yeah, Zach, great question. I mean, that's a holy grail question for sure. I mean, it's not an easy one to answer. I do think kind of the environmental stressors that are out there are tough to capture. We need to do a better job to figure out how to do that. Um, there are studies, there's another study that was published, but it was focused on actually individuals who have a specific genetic arrhythmia condition called long QT syndrome. And there's a lot of good work that comes from the Mayo Clinic and a guy named Mike Ackerman up there. And they looked at energy drinks related to cardiac arrest for those individuals who have long QT and showed an association. So and again, to be very clear, because I don't want anybody to thinking that this is a factual thing. This is still my opinion. I think stimulants are a big problem, and I think that they are more related to these events than we know. We just need to figure out a way to prove it. Um, they're at the collegiate. I take care of a lot of young athletes, and um, college is a lot different now than it was when I was there. And there's a lot of abused Adderall. That is not something that really occurred when I was a collegiate student. But there's a lot of ADHD that's been diagnosed over the years. It's kind of like the rave diagnosis, I feel like. And kids share stimulants. They do things that they shouldn't do. And so I just put that out there just as another example of like how much of this are just things that we just don't have a good handle on. Um, and then beyond that, that I don't think that would be the only explanation. There's just factors about this that we just probably may never understand as to why some of this sometimes this happens without a clear underlying cause. But it's a really good question and a good point, and certainly a good focus. I do think that it does still start off with the appropriate evaluation. I think in our field, we're still trying to make sure that people are doing the appropriate investigations, which include genetic testing. Um, I'm not sure that that happens universally as it should for some of these cases, but that's a really important part of the unexplained cardiac arrest case.
Okay, thank you. Josh Lupton has a question.
Yeah, great talk, and I appreciate it. And hold on my hand there. Yeah, so I am a cardiac arrest survivor. I think 9 days, it'll be 9 years, and it was during a half marathon. And I think one comment and then a question. The crazy thing is, I live here in Oregon. I'm a physician at our hospital at OHSU, and I was talking this morning to some local media because we had two cardiac arrests during half marathons in the last 2 weeks where both died, unfortunately, and they were both under
Mm,
20 years, which is crazy, particularly because, it seems like it's about 4 or 5 per year. And so thinking of your slide on the incidence and how it's been relatively stable, seeing that the HCM, the hypertrophic etiologies are much lower, to
yeah.
me, it makes me wonder if some screening strategies are working and there's some incidence that is actually increasing maybe a little bit more. And so we're screening out some who have kind of detectable causes and maybe those individuals aren't running. But then there's a larger portion in the background. I don't know if that kind of came into play in your thought process or if there's a way to look at that a little bit more, or if you have a comment.
Yeah, Josh, great question. I kind of look at it also a little bit differently in the sense that to me, there's no doubt that a lot of the reporting of HCM in prior studies, there were limitations with case ascertainment bias for sure. There's been a lot more focus as well on the pathological vetting of cases in kind of more contemporary athlete sudden death registries, which didn't exist in some of the older studies. And another thing that sometimes gets forgotten, and these are young competitive athlete registry data, is a lot of those earlier studies actually excluded the autopsy negative cases. So in some ways, the incidence and prevalence was kind of propped up a little bit more than it should have been. Um, I think there's no doubt that around the world that because this isn't just US data, but autopsy data from athletes in Israel and other countries have clearly shown that HCM is not the most common cause. I think to your point, yes, it is probably true, particularly for the young athletes, that there is some element of better capture of individuals. And not that those people can't play sports, because we now know that you can play competitive sports with HCM. You just have to be well managed and kind of risk stratified. And I think that may be probably what's going on, which is we're just doing a better job at taking care of HCM. I mean, the overall mortality rate from HCM now versus 40 years ago is like night and day. It used to be a kind of a death sentence, and now it's like many conditions that people can live normal lives with. Um, the other one thing I'll say about this is that these are recreationally active individuals, and so part of the reason why I think that the drop in HCM is probably less likely due to people being captured up front is that we don't really screen for HCM in any other patient population, right? For young athletes, we do a lot of ECG screening. People are getting mandated annually 14-point AHA history physicals. If you want to run a marathon, sure, you may have a PCP and they may ask you some basic questions, but you may not generally get an EKG until you get older anyway. Um, and there's just less of a kind of clear screening approach. And to me, I kind of interpret this as saying that to me is that there's probably a lot more HCM out there that we're fine running these events actually, and that our data is less of a we're doing a better job of just weeding those people out, and more so that it's probably a reflection that maybe our original data capture had some limitations. And my name was on that study, Racer. So I'm acknowledging probably in retrospect now that that was probably a limitation of that study, and that perhaps there wasn't as much HCM as the actual cause as we reported in that. And that's just by nature of how science has evolved overall anyway.
Uh, Hello, my name is Eric Zishi, and I could not figure out how to get the little green hand icon to pop up, but I assume that you can hear me, Dr. Kim,
I
and
got you.
Mary Newman, and all other fellow travelers out there. Salutations. So I had a question, Dr. Kim, as far as and I actually just typed it in, but as far as continuing athletic activity, once a person has had a cardiac arrest event, I am 64. I had my cardiac arrest about a year past, and it was actually during a athletic activity, though the athletic activities I've done through the years, though there have been a certain component of most certainly aerobic exercise. More, it probably leans toward anaerobic, in that I am a sport rock climber, and principally the last number of years, primarily boulder. So it's like shorter spurts of energy expenditure. And, but anyway, after I had my cardiac event, a bunch of doctors poked and prodded me, and the last I got from my one of my cardiologists about a month past, he said, "Oh, your numbers are all good. Just continue on." And so that's what I'm doing. I'm still playing the game, and though not at the elite level that I once did 30 plus years ago, I'm still, for my age, I would at least I'm still in the game, so to speak. And I'm just assuming that it's okay. I mean, at times I think, well, I wonder if this is maybe not the best course of action, but your thoughts there. And I got
Sure.
a little long winded there. Apologies.
No, no problem, Eric. And so I'm assuming you have a defibrillator placed after all of this,
I do
correct?
not. I do
You
not
do
have a
not.
defibrillator. No, the I had a coronary artery disease was the principal cause. The doctor,
Okay,
one of them assessed it as a plaque rupture,
got it.
and so
So
it
you,
was in the LAD. They
yep,
put in a stent, and
yep,
so
gotcha.
that is what they have done. And then going back just as a aside, when you were mentioning about, and that's awesome that they've had that increase in results as far as the survivorship for people in races, and the AEDs and the CPR are super important. I just thought I would mention as a slight aside, though the majority of the cases respond to the AED. Actually, when I went in my cardiac arrest and the person had done chest compressions on me at the gym, and then the emergency personnel came, I was actually one of the kind of lucky that it all worked out. I'm here happy to be chatting with you folks, but I was actually in PA, so the defibrillators
Yep.
did not work on me, and they
Yep.
tried defibrillating me several times, and actually en route to the hospital, they gave me a reasonable dose of epinephrine, and
Yep.
that got things moving again.
Yeah.
So
That's great.
so I just thought I would mention that, but they put in a stent, and that's what they have
Yeah.
done to address it.
Great. That's a incredible story. And yeah, so the short answer is after cardiac arrest, can you get back to competitive sport? The answer is maybe, and probably yes, but it does require um, getting the diagnosis right because there's certain things like Damar Hamlin, right? Like he almost required nothing after his event
Mhm,
because it
mhm,
was something that could have happened to all of us, and it was yeah, you can get back to sport. We had to make sure he had the right diagnosis though, so that has to be critical. You have to have the right treatments implemented. So in your case, a stent, and then getting on the right medicines.
right.
And then there has to be appropriate kind of risk stratification. And so
Mhm,
that
mhm,
is where you got to make sure that you've got the right person managing your condition and thinking through risk stratification, not just overall risk, but then for somebody who wants to get back to kind of a competitive level of training. And then
mhm,
once you've done all that, then there is this element of shared decision making, kind of
mhm,
putting it all together and figuring out after all that kind of where the qualitative risks are. That's where you're depending on the cardiologist to have the expertise to be able to give you that and
mhm,
to talk about, well, like where my risks are. If you've had a cardiac event, clearly you're in a new risk zone. Nobody's going to say that after a cardiac arrest, say maybe Damar, with kind of a fluky type thing, that you're once that happens, that you're ever going to get back to kind of the baseline zero level of risk or very low level of risk. There's always going to be that risk now there, but that doesn't mean that that's prohibitive to what you want to do. So
mhm,
I take care of plenty of athletes who have had cardiac arrest who have gone back to competitive sport. But it's just what you don't want is to have that. It's not a rubber stamp, though. I mean, anybody who says, "Yeah, sure, you can get back to sport," is probably under respecting the overall kind of all the factors involved. And then it's also the athlete as well. So there's some athletes that don't want to go back. They're just scared. I mean, I
right.
certainly have had folks that like, you know what, like I'm done. I'd rather just be healthy. Let me just do regular amount of exercise. I don't ever want to do that again because it really
Mhm,
scared me,
mhm,
even if you told me I could. And so there's all of these complex factors that have to kind of be put together. And so that is why the answer is maybe. Just it just depends on all these factors. But anybody who says gives you a flat out like no, you're done, they obviously don't know what they're talking about. And anybody who's just gives a flat out yes without kind of all these caveats, maybe a little bit too cowboy-esque. And what you really want to make sure is that you got the right person that's kind of guiding all of this, so then you're comfortable with everything and all the other stakeholders. So if it's a competitive athlete, we're bringing in family, coaches, trainers. If it's a recreational athlete, it's usually family members. That everybody is comfortable with these decisions, primarily driven by the athlete and their values and wishes in terms of what they want to do. That is guiding the process.
thank you very much, Doctor. That was I appreciate that answer. So then I'll just uh, put in one more quick query. As far as I live here in Utah, northern Utah, in Ogden, just north of Salt Lake City. Do you? Because obviously, most people that work within the field of cardiology and heart healthcare and such are not necessarily also like yourself. Have expertise in sports medicine and such. Any thoughts on this area? Is it something I can maybe just glean online, or as far as maybe finding someone to speak with here in this area regarding these thoughts? Because
Yeah.
I have them, and it's not like overriding. I mean, honestly, I'm hoping to have a number of years out ahead of me, but I've had a good life and I've enjoyed it, and I'm hoping to have a little more time. But
Yeah.
super
Yeah.
happy to be here, and
Yeah, there's a really good guy named Jared Bunch at Utah. He's an electrophysiologist, but he does take care of, so he's the guy who does like ablations and pacemakers. But he has kind of an expertise in the management of athletes. He's a name to look up if you want some, and he may be able to guide you to like a colleague of his at the University of Utah,
okay.
who does see kind of on the general side as well. But look up that name,
And what was that individual's last name?
Bunch,
Bunch.
Bunch. Yeah,
Got it.
Jared Bunch.
I'll be
He's
able
a
to find
super good
that.
guy.
Thank you, Dr. Kim.
You got it.
So we have several more questions in the chat, and we're at the end of our session now. Do you think Dr. Kim, do you think we can send you these later and you can follow up?
Sure, we could do a little like are some of these rapid fire? Try to get some of these I can give kind of short answers, and if there's any long ones I can say, maybe that's better to send me the to kind of give a more of a detailed answer. And before we do that, I do want to just say one quick thing because I know people probably have to start jumping off anyway. So the RACER study is not done. So we want to ask other questions. We want to look at what's going on since 2020. We want to try to find more etiologies. And we are going to kind of go back to the drawing board and reach out to participants again. So I noticed some folks here had either an event during a half marathon, or mentioned that they have the kind of running association with this. So the reach out can be huge as it relates to when you may hear about this, or if you talk to your friends, if somebody who truly had a cardiac arrest during a half marathon or marathon, just email me because maybe we haven't identified you, or we have, and for some reason we weren't able to connect, or maybe we did connect with you, and if so, thank you so much for helping Racer too. But we're going to keep with the study, and I think kind of people knowing about this makes the hugest difference for sure. And obviously, with the data that we published over the last with both of these, is really kind of made huge difference in terms of the care of athletes. So there's a question here. What's your email? So I can share it with you folks. It's actually pretty easy. It's just my name. It's Jonathan, Jon as in Nancy, Athan as in Nancy .Kim, Kim as in Mary, at Emory, EM as in Mary, ORY.edu. So feel free to email me. And yeah, so I just wanted to put that plug out there in case people just start jumping off. And then maybe I can do like one or two more questions.
Okay, thank you. I think Karen Sheets Mobley has asked a few questions. Karen, do you want to?
Yeah, I can try to sum it up really quick. So my husband had a cardiac arrest, and so now wherever I go, I'm looking for AEDs. My nephew runs cross country, and because he's always at the front of the pack, I'm always worried about kids at the end. It's like unless there's someone following them, do we have now Kentucky has more policies about AEDs being on the playing field and such, but is this something to advocate for? Like where are AEDs along the line? I mean, that's a long track. And,
Yeah.
with half marathons and stuff, where are they placed along the
Yeah.
route?
Yeah, no, absolutely. That was kind of what we talked about with the end being the most common. So it's all about strategic deployment. Where do you put your assets? Because you obviously can't have AEDs every 100 yards on a 26-mile, 13-mile course, right? But you know where they occur. And being a part of the Peachtree Road Race, what you find actually is very strategic planning. And usually the way this is designed is you have kind of a kind of a collapsing down on the event. So you can't send people from the end of the race upstream. What you do is you have people on the backside following the race in. And so usually what we have are kind of bikers with the AEDs on their backs, kind of as the race moves forward, they are at the backside there as everything kind of collapses down to the end. And so that's a part of that strategic deployment as well.
Okay, thank you, everyone. I think we have to wrap it up here, but we'll follow up, Dr. Kim, with connecting you with people that had additional questions, if that's
Sure.
okay. And
That's
so, yeah, we want to mention that our next um, meetup will be on May 15th, and it's on managing difficult emotions after cardiac arrest, which will be facilitated by psychologist Alex Prejuti. And there's information on this slide regarding our newsletter and supporting Sudden Cardiac Arrest Foundation. So thank you very
Th-
much, everyone, and we'll connect you with Dr. Kim if you have additional questions. So great
thanks
attention.
everyone. And if people email me, I'll certainly I will try to get back to everyone. If it takes a few days, I will respond for sure. So thanks guys for having me.
Thank you, everyone.